Good afternoon, everybody. My name is Norma O'Leary. I'm one of the palliative medicine consultants here, and I'm surprised to see some individuals here because there's some very experienced people here in the audience. So there probably will not be a lot new in what I'm talking about, and it's certainly more relevant for the new recruits to the hospice. So my brief this afternoon is to talk to you about the management of cancer pain with a particular focus on how we use the WHO analgesic ladder. So this is really following on from what Noreen was speaking about, and really the management of pain is all about the assessment. And really, as the doctors, we're very much dependent on the holistic assessment that's done by the whole team, and really the nurses are absolutely key to the management and to the assessment of pain from the time we first meet the patient, but on an ongoing basis, because a nurse will give an insight into how a patient is both daytime and nighttime that we as the doctors don't necessarily appreciate. And it goes back to this concept of pain being a subjective symptom. It's very much what the patient says hurts. There are very formal definitions about pain. The International Association for the Study of Pain is one that we frequently refer to: an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. But basically, pain is what the patient says hurts. And we know that pain is a frequently experienced symptom in patients with cancer. And in patients with advanced cancer, up to 80% of patients will have some experience of pain. And it's probably the most feared of all symptoms. Patients with cancer assume that they're going to have bad pain, and they assume that the pain is going to get worse as the disease progresses. Now, they are assumptions. Just because your disease is progressing doesn't necessarily mean that pain is going to worsen. But at the same time, pain is a very prevalent symptom in patients with advanced cancer. And as Noreen alluded to, we have to really assess patients to determine the quality of the pain that they're experiencing, because frequently patients will have lots of different pains feeding into their total experience of pain. So we say that of those cancer patients, 1/3 will have one pain, 1/3 will have two pains, and 1/3 will have three or more pains. So again, it goes back to the importance of pain assessment. And just because a patient has cancer, we can't assume that all their pain is down to the cancer itself. And just because you have a diagnosis of cancer, it doesn't mean that all your other comorbid conditions go into abeyance. So, the pain may be due to the cancer itself, it may be due to the treatments that the patient has undergone, or it may be due to their comorbid conditions. Again, this classification of pain may seem irrelevant when we're on to the management of pain, but it's not at all. In fact, it's very important that when we are assessing a patient's pain, we really determine from the history what sort of a pain the patient is experiencing. So pathological pain is broadly classified into two groups, either nociceptive pain or neuropathic pain. And nociceptive pain is further broken down then into visceral pain and somatic pain. Neuropathic pain really indicates that a patient has some type of nerve damage or nerve irritation. And it's really from the patient's history that we determine whether a patient is experiencing nociceptive or neuropathic pain. And if you hear, as Noreen said, descriptors like stabbing, burning, a toothache sort of pain, or classically where the patient says, well, I can't really describe this pain, or I'm having difficulty telling you about the pain, well, then you need to start thinking, could this patient have a component of neuropathic pain? So knowing whether the patient has nociceptive pain or neuropathic pain does guide our prescribing. And the vast majority of patients with cancer actually will have a mixed type of pain, so they'll have mixed nociceptive and neuropathic pain. And as Noreen said, we really talk about this concept of total pain, because not only do patients have physical elements to their pain, but they'll also have psychological, spiritual, and social factors feeding into the pain. And why is that important? Well, it's important because a drug, a pain relieving drug, is not going to treat the psychological aspects of the patient's pain. It's not going to address the patient's spiritual distress. It's not going to support them from a social perspective. And similarly, giving a patient an anxiolytic is not going to really treat the physical nature of their pain. So it's very important that we're really assessing patients holistically to determine what are the factors that are fueling the patient's pain experience. And again, in Noreen's assessment of the pain, we need to determine, we need to ask the patient about their experience of persistent pain and then their experience of breakthrough pain, because the experience of breakthrough pain needs to be managed slightly differently to their background pain control. Probably the most important message I would give to you today is never treat a pain you don't understand. So if you have a patient that you're looking after and they're telling you about a pain that doesn't make sense to you, well, then we shouldn't just be jumping in with pain relief. A question that I always ask myself when I'm seeing a patient for the first time is this pain consistent with a site of known disease? And if it's not, well, then we need to think again. Does this patient need further imaging? Because has the pain progressed, or has the cancer progressed? Or actually, is this a pain that's not related to their cancer at all? Is it related to their comorbid conditions? So please, never treat a pain you don't understand, because we have to go back and determine what exactly is causing this pain. So for the management of cancer pain, we refer to the WHO analgesic ladder. And again, you'll all be familiar, I'm sure, with this ladder at this stage. It's very simple. There are 3 rungs to the ladder. The first rung of the ladder refers to the management of mild pain. The second rung of the ladder refers to the management of moderately severe pain. And then the third rung of the ladder refers to the management of severe pain. And on each rung of the ladder then we use different analgesic agents. So for patients with mild pain, we use simple analgesia. So we talk about paracetamol and anti-inflammatory drugs as being simple analgesic agents. For patients with moderately severe pain, they need to be stepped up to the second rung of the ladder, and that's where the use of mild opioids comes into action. And then if a patient has severe pain, well, then they'll need a strong opioid. On each rung of the ladder, we're also allowed to consider prescribing adjuvant analgesic agents. Now, adjuvant analgesic agents are drugs in themselves that were not primarily developed for the management of pain, but when they're used in conjunction with analgesic agents, they can help in the management of pain. There is a school of thought out there that suggests that maybe we should just abandon the second rung of the analgesic ladder, because the second rung of the analgesic ladder refers to the use of codeine and tramadol. And for any of you who have looked after elderly patients in particular, you'll know that elderly patients tolerate high doses of tramadol and codeine very poorly. And actually, a small dose of a strong opioid is generally better tolerated than a large dose of a mild opioid. And for all those reasons, some people suggest that we should abandon the second rung of the analgesic ladder. We apply the analgesic ladder by the mouth, by the clock for the individual, and we attend to detail. So what I mean by that is it's most convenient for a patient to be given their drugs by mouth. So as a result, we should always try to give analgesia by mouth if at all possible. By the clock, because patients will have background pain all the time, we need to give them regular analgesia to manage that pain. So it's no good if a patient patient has chronic cancer pain and they're experiencing it 24 hours a day, there's absolutely no point in giving them a short-acting opioid in the morning and leaving them without pain relief for the rest of the day. So think about pain relief for the 24 hours of the day. And all pain management needs to be individualized, because we talk about this concept of pain being a subjective experience, the total pain experience, and as well as that, we are all built differently. So all of us have different opioid receptors in our bodies and opioid receptor subtypes. And we're not so sophisticated in modern medicine that we can prescribe the drug that the person we know will tolerate. So for example, I may be able to tolerate 5 milligrams of morphine, and at a dose of 10 milligrams I get opioid toxic, whereas somebody else in the audience may be able to tolerate 100 milligrams of morphine without any evidence of opioid toxicity. And why is that? It comes back to all of our opioid receptor subtypes. We all have different subtypes, and we're all built differently in our ability to tolerate these opioid drugs. So for any of you now, or all of you working in a specialist environment, you do need to be aware of the pharmacological management of cancer pain in adults. So this is a guideline that was produced by the Clinical Programme for Palliative Care. It's an evidence-based guideline for the management of cancer pain, and it's our go-to document when it comes to looking at the evidence for what we do. You can get it if you just Google HSE Department of Health and Pharmacological Management of Cancer Pain in Adults. And as I say, it's a very, very useful reference document. It talks about, there are very useful chapters in it. So how do we manage pain in patients who have a history of addiction? How do we manage cancer pain in patients who have liver failure or renal failure? So it's a useful document to be aware of. So, as I said, there are 3 rungs to the analgesic ladder. The first rung refers to the management of mild pain, the second rung, moderately severe pain, and the third rung of the ladder is severe pain. And on each rung of the ladder, we can consider the addition of adjuvant analgesic agents. And as I said, these are drugs that are in themselves are not primary analgesic agents. So you can see on the left-hand column, you've got steroids, antispasmodic drugs, antidepressant drugs, anti-epileptic drugs, muscle relaxing agents, and bisphosphonates. So they, in combination with primary analgesic agents, can help in the management of pain. And they're particularly useful if you have a patient where they have a nervy component to their pain. So you'll remember that when I said earlier that the vast majority of patients will have mixed nociceptive neuropathic pain, but if you're hearing the descriptors of burning, shooting, stabbing, toothache pain, well, these drugs in particular have a role. Some of you will be looking after patients and they're asking you about cannabis oil and why aren't we prescribing cannabis oil for the management of cancer pain. Because I suppose in social media in particular, in the cancer world, there's a lot of I suppose misinformation out there where people are being persuaded that maybe cannabis oil will offer a cure for your cancer, or cannabis oil is in some way going to be superior to the other drugs that you're on for the management of cancer pain. And you need to inform your patients to let them know that there is no evidence for either of those suggestions. There's no evidence to support the premise that cannabis oil will cure cancer or will be effective for the management of cancer pain. If you were to think about cannabis oil in the WHO analgesic ladder and where would it fit, it's not an opioid, it's a cannabinoid agent. So you would think of it perhaps as an adjuvant analgesic agent. But as I said, so you wouldn't be, if you were somebody who believed in the role of cannabis oil for the management of pain, you might consider it an adjuvant analgesic agent. So you still wouldn't be abandoning the opioids for the patient. But there was a big review done actually just last year by the Health Products Regulatory Authority, and their conclusion was that there is some evidence for the use of cannabinoids in the management of intractable epilepsy, the spasticity of MS, and for chemotherapy associated nausea and vomiting. So there are 3 very specific indications for cannabinoids in the Irish setting at the moment. So some patients can get access to cannabinoids, but currently there is no evidence for cannabinoids in the management of cancer pain. So opioids in the management of cancer pain. So already we're on to the second rung of the analgesic ladder. So we're talking about patients with moderately severe cancer pain, and the drugs that we consider as weak opioids are tramadol and codeine. And as I said, generally as a rule of thumb in the palliative care world, because the vast majority of our patients will have moderate to severe pain, we tend not to use these drugs, and generally they're poorly tolerated, particularly in the older population. But if you are stepping a patient up from a mild opioid to a strong opioid, it's a 10-to-1 conversion ratio. So if you have a patient on the maximum dose of tramadol, which would be 400 milligrams in a 24-hour period, if you were to step them up to a strong opioid, that would be the equivalent of 40 milligrams of morphine in a 24-hour period. We tend not to go to 40 milligrams of morphine, however. When we're stepping a patient up to a strong opioid from a weak opioid, we tend to err on the side of caution. So if I were changing somebody from a maximum dose of a weak opioid to a strong opioid, I probably would start at about 10 milligrams of MST twice a day. You're always better off when you're using strong opioids to err on the side of caution, because you'll always have the backup of instant release preparations. But if you overshoot the mark at the beginning with a strong opioid, you'll frighten the patient, because they will get drowsy, they may be a little bit nauseated if the dose is just too much for them on initial exposure to the opioid. So generally, as a rule of thumb, always err on the side of caution, and go slow with the titration of the opioid. So strong opioids, again, you'll be familiar with most of these drugs at this stage. The strong opioids that are available to us here in Ireland are morphine, oxycodone, hydromorphone, fentanyl, alfentanil, buprenorphine, and methadone. Generally, when we're prescribing drugs, we use the generic version of the drug, but opioids are the exception. So when we're prescribing opioid medications, we will always use the trade name or the drug name, because it differentiates between the slow release version of the drug and the instant release version of the drug. So if I were to prescribe just morphine sulfate in the drug chart, on the oral side of it, you would, as the nurse, give the instant release version of the drug, whereas I may have meant MST, the slow release agent. So if you see morphine sulfate, it's the one exception when we are prescribing that we use the trade names. So if you do see morphine sulfate written in the drug chart, for oral administration, you do need to check with the doctor, do they actually mean the slow release version of the drug? And in that case, it should be charted as MST. So the slow release version of morphine sulfate is MST, and the instant release version then is either Severdal or Oromorph. Oromorph is the liquid version, and Severdal is the tablet version. For oxycodone, the slow release agent is OxyContin, and the instant release agent is Oxynorm. And you know that Targan is a combination drug of oxycodone and naloxone. and there is some evidence to suggest that it's a less constipating drug than OxyContin. In practice, I'm not sure that we're convinced that it is that superior when it comes to preventing constipation as a result of opioids. Hydromorphone then, it's Palladone slow release, Palladone instant release, fentanyl you'll be familiar with, Duragesic, and the rapid onset opioid fentanyl preparations, Effentora, Abstral, Instanil. So you'll be familiar with these names at this point in time. So when we're stepping a patient up to the third rung of the analgesic agent, the analgesic ladder, which drug should we choose? What do we think should be the drug that we rely on first?
On the third rung?
On the third rung of the ladder. Yeah, so a strong opioid. Morphine. Is everybody in agreement with that? Has anybody come from an acute hospital? No, because if you were working, I'm sure some of you probably have come from an acute hospital, and you probably would be saying oxycodone, because actually OxyContin is widely prescribed in our acute hospitals, and actually it's probably the drug that is most frequently prescribed by non-palliative care physicians. And there's no reason for that other than it being a marketing masterstroke. So when these drugs came on the market about 20 years or so ago now, the drug company persuaded us that oxycodone was superior to morphine, and that it was superior particularly for nervy type pain. But actually, when you looked at the studies that they were basing this information on, they were comparing oxycodone to placebo in patients with diabetic neuropathy. So, you know, but if you didn't actually ask about the evidence, you can see how swayed you would be. And that's really how oxycodone became so widely prescribed in really most of Western Europe and in the States as well. But actually, morphine sulfate should be our first line opioid, our first line strong opioid that we prescribe. It's cheaper than oxycodone, and it is the gold standard drug. It's the drug that we have most familiarity with, and actually it's the drug that we based all of our other conversion ratios on. So for example, we think about oxycodone being 1.5 times as potent as morphine, hydromorphone being as 5 times as potent as morphine, whereas, you know, if you're starting with oxycodone, particularly in the acute hospitals, you would frequently see patients being prescribed OxyContin 10 milligrams twice a day, and that's actually a pretty big dose of opioid for initial exposure to a drug. So we prescribe any opioid generally by the mouth, and we administer it by the mouth if at all possible. The starting dose of a strong opioid is determined by what other drugs the patient has been on and the severity of their pain. So you'll remember I said if a patient is on the maximum dose of a mild opioid on the second rung of the ladder, well then you would probably be starting off at a dose of about 10 milligrams twice a day of MST. If, however, you're skipping the second rung of the analgesic ladder, you need to think about very low doses of the strong opioid. So you might think about Oromorph 2.5 milligrams 4 hourly regularly if the patient is opioid naive. And you know that the breakthrough dose of the opioid should be 1/6 of the 24-hour dose. And how do we titrate up then the dose of the opioid to achieve pain management? Well, 2 factors really will determine what you do. Firstly, your pain assessment. So what the patient is telling you, have they been admitting to pain? Have they been looking for breakthrough pain medication, or actually have they been exhibiting pain behavior but not telling us about it? So it's down to your skilled assessment of the patient's pain, as well as how much breakthrough pain medication the patient has been taking. So it's very simple. I mean, when we're going around on the ward round on a daily basis, we will look back on how much breakthrough pain medication the patient has needed in the previous 24 hours, and we will add that into the prescription for the day that we're in. So for example, if a patient is on 10 milligrams twice a day of MST and they've taken 4 2.5 milligram doses of Oromorph, you would probably step them up to 15 milligrams twice a day of MST. So it's, you know, it's pretty intuitive. It's not rocket science, but you must remember that the amount of breakthrough pain medication the patient is taking doesn't necessarily fully reflect the patient's pain experience, because they may be under calling and under reporting to the nurses that they have pain, or actually they may be overly relying on breakthrough pain medication. So they may have psychological distress and they may be asking for a pain medication. So it continuously comes back to the skilled assessment of the patient's pain. So I'm going to now quickly skip through the different strong opioids. Oxycodone is 1.5 times as potent as morphine. If you've worked outside Our Lady's Hospice, you may be familiar with a 2-to-1 conversion ratio. We use a 1.5-to-1 conversion ratio here. Oxycodone is a good drug. It's not superior to morphine though. Hydromorphone is 5 times as potent as morphine. Again, it's a good drug. The one drawback, however, is the instant release preparations. It only comes in 1.3 and 2.6 milligram tablets. So if a patient is on a very high dose of background Paladone, they end up actually needing to take lots of tablets for their breakthrough dosing. So it's slightly cumbersome from that point of view. There was a school of thought that suggested that hydromorphone was superior to morphine or oxycodone in patients with renal failure. There's no evidence to support that at all. And then fentanyl patches and buprenorphine, these are actually very convenient ways of administering pain medications to people, particularly if they have stable pain and particularly if the patient has difficulty swallowing. So very frequently we would use patches if a patient has a head and neck cancer in particular and they have difficulty swallowing. You need to be careful, however, with fentanyl patches. They're not useful in patients who have unstable pain, and you also need to be careful in patients if they are septic. So if a patient has a fentanyl patch on and if they become pyrexial, they will vasodilate, and as a result there's a potential that more of the opioid will be absorbed into the patient's system. So they're more at risk of becoming opioid toxic if they're very septic, if they have a fentanyl patch on, versus if they're on just a regular oral opioid. I'm not going to go through changing the routes of administration, but we have a lot of information on the intranet and it's all been produced by the pharmacy. Very, very, very useful tables as to how to convert the route of the opioid. So to convert from the oral to the subcut route, to convert from the oral to the transdermal route, from the transdermal route to a syringe driver. You need to be careful about the timing of when you stop the drug to start the new route of administration. And these tables you always need to refer to, and they're up on the intranet on our website. So, just a couple of words about fentanyl transmucosal preparations. So these are known as rapid onset opioids. So fentanyl, when it is administered transmucosally in the form of Effentora, Actique, Pecfent and Abstral, they're known as rapid onset opioids. They're rapid onset opioids because fentanyl is a very lipophilic drug. It's absorbed very quickly across the buccal mucosa, and patients get pain relief very quickly. So we know that if a patient has breakthrough pain, the time to peak intensity of the pain experience is about 10 minutes. When we give an instant release opioid, so if we give a patient Oromorph or Severdal, it may take about 20 minutes for that opioid to kick in, so you've almost missed the peak intensity of the episode of breakthrough pain. And if you give a patient the opioid subcutaneously, it may take about 15 minutes for the opioid to start kicking in. So you can see that these rapid onset opioids, because they kick in within about 10 minutes, they're very effective for breakthrough pain. But we need to be careful with their use because, again, a bit like when oxycodone came on the market, when these drugs came on the market, again, they were seen as absolutely fantastic drugs because they were very convenient for a patient to take them, and because they weren't called morphine, they were very acceptable to patients. And there was a population of patients with non-malignant disease in the States who started using these drugs, and there were a number of sudden deaths. So for example, there were frail, elderly little ladies with rheumatoid arthritis and osteoarthritis taking these drugs, and they had sudden deaths. So we now know that a patient has to be opioid tolerant, so they have to have some opioid in their system, and we say they need to be on about 60 milligrams of morphine in a 24-hour period before we can consider prescribing these rapid onset opioids. And the reason being is that we need to reduce down the risk of respiratory depression because you're rapidly sending in the opioid into the patient's body. For those of you working in Our Lady's Hospice and Care Services, we don't use fentanyl subcutaneously, we use alfentanil subcutaneously. We use it very frequently because patients that are admitted to the hospice tend to be more complex, tend to have rotated through a number of opioids, and frequently tend to have renal and liver impairment. And why do we use alfentanil? We use it because it has inactive metabolites. So the reason why patients get opioid toxic is because the metabolites of the opioid builds up in the patient's system, whereas in alfentanil the metabolites are inactive, so the patients don't tend to get as much neurotoxicity as they would with some of the other opioids. So alfentanil is a very useful drug, and we tend to use it for patients with liver failure or renal failure. And 1 milligram of alfentanil subcut is the equivalent of 15 milligrams of morphine sulfate subcut. Methadone, again, is a very useful drug. It is an opioid agonist, but an NMDA receptor antagonist. So it's slightly different to the pure opioid agonists that we've been talking about, such as morphine and oxycodone and fentanyl. So it has a role specifically in patients who have severe cancer pain, particularly when there is a neuropathic element to their pain. Methadone, switching a patient to methadone generally requires the patient to be an inpatient because methadone has a very long half-life, and after about day 3 or 4 of the patient being exposed to the opioid, there's a risk that they may get a little bit opioid toxic, and we need to tweak the dosing of the methadone. So switching a patient to methadone isn't as straightforward as switching a patient to other opioids, and that's because of its very long half-life. So, opioid rotation or opioid switching. I spoke to you at the beginning of the talk that we're all built differently when it comes to our opioid receptors and our opioid receptor subtypes. And there was a lot of work being done about 5 or 6 years ago in London, where they were trying to see, could we actually get to a point where we would be able to describe the opioid receptor subtype profile of people, so that we would be in a position to really individualize our prescribing of opioids, so that I would know that actually I'm somebody who'll do better on oxycodone, whereas you might be somebody who does better with fentanyl, but we're well away from having that ability to to prescribe in such a sophisticated way. So unfortunately, there is a degree of trial and error when it comes to our opioid prescribing. We say we tend to start with morphine as our first line opioid, and the thing about opioids is that they're pretty magical drugs. There is no ceiling dose when it comes to their analgesic effect. So we can continue to prescribe a dose of an opioid, continue to go higher and higher, and the patient will continue to get benefit from a pain relief point of view. But what limits our prescribing of opioids is the patient's ability to tolerate the drug. So at some stage, the patient, because of their opioid receptor subtype profile, will start to get opioid toxic. So if you've got a patient and they have pain, what we do is we titrate up the opioid to either effect or toxicity. So effect is when the patient's pain is controlled, and then you stop you stop titrating up the dose of the opioid. That is the correct dose for that patient if they're pain controlled. If, however, you get to a point where you've pushed up the dose of the opioid, the patient is still in pain and they're starting to experience opioid toxicity, well, what do you do at that stage? You could, in theory, continue to titrate up the dose of the opioid because the patient will still experience pain relief, but you're also just going to expose the patient to further opioid toxicity. And as a result, they're going to be groggy, they're going to be drowsy, they're going to be delirious, they may have hallucinations, they may have vivid dreams. So that is absolutely no quality of life for a patient. So if you've got a patient who is starting to experience opioid toxicity and their pain is not controlled, well, that is the indication and that is the time to consider switching them to an alternative opioid. And the hope by switching them to an alternative opioid is that it will be a drug that they will tolerate better related to their opioid receptor subtype profile. And we need to switch up to 40% of our cancer patients. So they'll need to be switched from morphine to an alternative opioid. You recognize opioid toxicity by symptoms and signs. So drowsiness, confusion, the patient telling you that they're having visual hallucinations, the patient telling you that they're having vivid dreams, but they're not going to tell you unless you ask them, particularly a patient who's having very vivid and troublesome dreams and frightening dreams. That can be a sign of early opioid toxicity, and if you don't ask them, they're not going to offer you that side effect because they'll just assume that they're losing their mind. And the signs of opioid toxicity would be myoclonus. So that's that kind of subtle tremor of the hand, which is different to the kind of the flap or the tremor of somebody with liver failure or carbon dioxide retention. So the best way of checking for myoclonus is literally to ask the patient to close their eyes and to put their hands out, and if you see that subtle tremor, that is opioid toxicity, until proven otherwise. Some people will say pinpoint pupils are a useful indicator of opioid toxicity. They're not, because our pupils are changing all of the time dependent on the ambient light. So right now, we're probably partially opioid constricted because of the light, but we're not partially opioid toxic, I hope. There's a difference also between opioid-induced side effects and opioid toxicity. So all patients on initial exposure to an opioid will feel a little bit groggy, a little bit drowsy, and they may also feel a little bit nauseated. These symptoms of initial exposure to the opioid tend to settle down after 2 or 3 days. So the patient's body will become tolerant of those initial side effects. So when you're starting somebody on a strong opioid, it's very important that you warn them that they may feel a little bit drowsy for the first day or two. And some people actually will co-prescribe an antiemetic when somebody has been started on a strong opioid for the first 2 or 3 days. And we know that elderly ambulatory females, for whatever reason, seem to be more sensitive to the nauseating effects of opioids on initial exposure. So just to be aware that those side effects the patient will become tolerant of after a couple of days. The one side effect of opioids that patients do not become tolerant of is constipation. So as long as a patient is on an opioid, they generally need to be on a laxative, and it's really remiss of us as palliative care people not to be assessing patients' bowels as regularly as we assess their pain control. We talk about 3 levels of opioid toxicity: mild opioid toxicity, moderate opioid toxicity, and severe opioid toxicity. So severe opioid toxicity is a patient that has a respiratory rate of less than 8, is cyanosed, and is becoming delirious. And if you have a patient that has a respiratory rate of less than 8 and is cyanosed, well, that is an indication to give them naloxone. In my career, I would say I've used naloxone twice ever, and I prescribe opioids every day. So it's extremely rare do we need to rely on naloxone if opioids are being prescribed carefully and judiciously. And actually, there was a patient safety alert from the NHS in the UK back in 2015, where they were saying actually that naloxone was being prescribed really inappropriately for patients on opioids. And again, rather than the naloxone being a life-saving drug, it was actually being turned into a life-threatening drug because it was being used and administered inappropriately to so many patients that were on opioids. Because if you give a patient naloxone when they're truly not experiencing severe respiratory depression, they're going to have a severe withdrawal from the opioid. And withdrawal symptoms, we describe it as the wet syndrome, so runny eyes, sweating, shivering, and very, very uncomfortable. And it can really have a physiological effect on the patient where they're tachycardic and make people physiologically very unwell. And it also really complicates the pain management then. So if you've given somebody naloxone when they truly didn't need it, you're back to square one then, because the patient has withdrawn from the opioid, so now you have exposed them to pain as well as having had a very unpleasant withdrawal experience. So for lots of reasons, we rarely have to give naloxone, and it is for those very rare patients that truly have severe opioid toxicity. So which drug do we switch to if we have a patient who has poorly controlled pain and is exhibiting signs of opioid toxicity? Well, your choice of opioid will be determined by what opioids the patient has previously been on, It will be determined by the patient's liver and renal functioning. It will be determined by what is the most convenient route of administration of the drug. So all those factors you need to consider when we're switching from one opioid to another. And again, now this is actually from St. James's Hospital, but we have a conversion table here in Our Lady's Hospice. Again, it's up on the intranet, and it helps us to determine what is the correct dose of opioid when we're switching from one opioid to another, dependent on the conversion ratio. We've talked about constipation and the importance of patients being on laxatives. So morphine should be our first line opioid. Generally, it's the rare exceptional patient that will experience respiratory depression. If the patient is opioid toxic, is it that you've just overshot the mark with the opioid and you need to pull back? Or is it that the patient still has poor pain control and you need to think about switching the opioid? Breakthrough dose is 1/6 of the 24-hour dose, and when we're switching from the oral to the subcut route, it's 2-to-1. Always remember to prescribe laxatives. Now, have I 3 minutes just to... Yeah. So there are just 4 cases that I want to briefly mention. So if you have a 53-year-old lady, she's got pancreatic cancer, and the only drugs she is taking are OxyContin, 35 milligrams BD, and she's taking paracetamol, a gram QDS, and she's nauseated. What's the first thing you would start to think about?
What's causing her nausea?
Yeah.
Is it a drug or is it her condition?
Mm-hmm.
And how often is the nausea occurring? Is it always there in the background?
Mm-hmm.
And possibly adding in an antiemetic because there's none there, but also looking at her whole thing. Like she's on an opiate, so is it nausea because there's some kind of blockage outside of the pancreatic cancer, like constipation? You need to take a good history, clinical history.
Yeah. So it's there. This lady is on an opioid. She's not taking a laxative, so it's most likely that she's constipated. Yeah. So think about the simple things first. I would never prescribe an antiemetic unless I understand what is causing the nausea, because your choice of antiemetic will be determined by the cause of the nausea. So just a simple case. The second one, an 82-year-old gentleman with prostate cancer and bone mets, and he has back pain that's radiating down one leg. He's taking tramadol, 200 milligrams QDS, and paracetamol PRN.
Well, what is the type of pain that he's experiencing?
Yeah.
It's saying back pain, radiating. You'd ask him, what way does it you won't be answering all the time. You'd ask him what type of way the pain is. Is it a burning sensation? You try and clarify what kind of pain. Because like there's 2 things mentioned there, prostate and bone, you know. And then the tramadol is not a neuropathic pain relief.
Well, opioids do work for neuropathic pain.
But just you might consider adding that in. But
so considering his current pain is not being managed on the regimen that he wants. So you look at the next.
Yeah. So there's 2 things. There's the pain assessment, so what's causing the pain, and then there is what is the appropriate changes, what appropriate changes need to be made to get better pain relief. But do I understand the reason why this man is having pain? So the first thing is, you'd be looking at his scans. So can we explain his pain by the sites of known disease? When we hear back pain in palliative care, we're paranoid about spinal cord compression. Is this story suggesting that he has spinal cord compression, pain radiating down one leg? Perhaps not. That might indicate more radicular type pain. For patients with spinal cord compression, the kind of the worrying symptoms in the history would be a worsening of the pain in the back, tenderness on the spine, pain that's radiating around both sides, or pain that's radiating down the buttocks into the legs, pain that's worse when the patient coughs. And there was those descriptors of nervy pain, shooting, burning. I find it difficult to explain the pain that I'm having. And then, if you're happy that actually this is just back pain related to a vertebral met that's tipping off one of his nerves, well then you might be happy just to titrate up the opioid. And then the question is, do you just push up the dose of the tramadol, or do you switch to a strong opioid plus or minus adding in an adjuvant analgesic agent? But opioids do work for nervy type pain. Third case then, a 60-year-old lady with breast cancer with liver and lung mets. She's taking MST 40 milligrams BD, and she's not taking any PRN medication. She's drowsy.
The liver metastases could be changing how the drug is being metabolized. So toxicity is a possibility.
Yeah. So you're thinking that she might be opioid toxic. So what would you do if that is your diagnosis?
Reduce, get her, well, not necessarily rotate. You could put her on a short-acting alarm and see.
Well, so this lady, she's not taking any breakthrough pain relief, so that might indicate that her pain is controlled. Maybe it's too well controlled, so maybe we just need to pull back on the dose of the opioid. So if a patient is opioid toxic, what you do is determined by their pain control. If they are pain controlled, you might have just overshot the mark with the prescribing and you need to dose reduce. If, however, they're opioid toxic and they still have pain, then you need to switch.
So you dose reduce by 30% or what?
Yeah. Okay, that's it. Okay, thank you very much.